Hi, everyone, and welcome to the next installment of Impilo's webinar series, CPT Billing for RPM Without the Headaches, What You Need to Know for 2025. And just so everyone is aware, this webinar is being recorded and will be sent to everyone who registered and is attending today. We're so happy to have you all here with us today. I want to start off by introducing ourselves. I'll go first. My name is Chelsea, and I'm on the marketing team here at Impilo. This is Josh and Harsh. Do you both want to introduce yourselves?
Sure, I'll go first. Hi, everyone. My name is Josh Stein. I'm the founder of Impilo.
Hi, everyone. My name is Harsh Ramatla. I'm a senior manager here at Impilo, working on the accounts and customer success team post-sale. Thank you, everyone, for joining.
Perfect. I'm just going to share my screen because I just realized that I forgot to do that. Awesome. Alrighty. So let me just wanted to make sure that it was recording. So sorry about that. Awesome. So I am going to go over our agenda items for today. So first, we're going to go over who is Impilo for those of you who are joining us for the first time. Josh is going to go over that. And then Harsh is going to go over the CPT codes for remote patient monitoring, requirements for billing codes, new changes to RPM in 2025, and how Impilo can help. We will be having a Q&A at the end, so feel free at any point in time, pop your questions into the Q&A, and we'll make sure to answer them at the end. And just as a little reminder, we are not billing experts, so this webinar is intended to provide general information about remote patient monitoring billing. For specific billing questions or advice, please consult your billing team. And I am going to pass it over to Josh to introduce Impilo.
Thanks, Chelsea. So before we get into the nuts and bolts of RPM billing and what it's all about and what's changing in this next year, always like to introduce who we are and kind of what we do in this space. Um, a lot of people think of us as an RPM company. A lot of people think of us as a SaaS solution. A lot of people think of us as a 3PL solution. Uh, the truth is, we're really an operational layer to help those who want to use devices and medical supplies in the home. And one of our kind of most prominent and popular use cases is running different RPM programs through us, on us, with us. Um, and really, our kind of most kind of likely and I'd say where there's the greatest benefit partner-wise is partnering with groups that really want to handle and own the clinical side end to end. And we are very proud and feel humbled to be able to work with such innovative and cool clinical offerings across the healthcare space. So today, excited for have Harsh kind of go through, what a lot of our customers work through from a CPT perspective and how they actually get paid for doing some of their activities in RPM. But we also work with a lot of groups that might be doing RPM in a non-fee for service manner, in a value-based care manner, or in other more direct-to-consumer opportunities. And so if that fits what you're doing today and it's something you're interested in, feel free to reach out to me or the team after this webinar about how we can help support that. I'll pass it back to Chelsea to keep us going.
Awesome. Thanks, Josh. Now we're actually going to turn it over to Harsh to dive into some key requirements for RPM, as well as some CPT codes for remote patient monitoring.
Thank you, Chelsea. Again, good afternoon, and thank you, everyone, for joining us today for our webinar, CPT Billing for RPM Without the Headaches. I'm sure most of the attendees are familiar with the requirements for remote patient monitoring or RPM, but just as an overview, I want to review what the requirements are and a few billing considerations associated with submitting claims to payers for remote patient monitoring services. So going into the key RPM requirements, coming off of the public health emergency in 2023, an established relationship is now required to furnish RPM services, meaning that RPM can only be prescribed for a patient if there is an established patient-provider relationship. That patient must have an acute or chronic condition that necessitates monitoring. In order to participate in the program, that patient must collect data 16 days out of a 30-day billing period. Only one practitioner can bill for RPM for a patient at a time. You cannot bill RPM and RTM, remote therapeutic monitoring, concurrently, but you can bill remote patient monitoring and chronic care management, principal care management, transitional care management concurrently. Additionally, patient consent is mandatory for participating in a remote patient monitoring program, and data must be electronically collected and automatically uploaded to a electronic cloud-based server, and it must be collected via a FDA-defined medical device. So that is essentially what the requirements are for a patient to participate for RPM, but also the requirements for successful submission of claims to reduce the chance of RPM claims being denied for medical necessity or any other reasons for denial. That being said, as a brief overview of what the requirements are, we will now very briefly go over what the CPT codes that actually can be billed for remote patient monitoring are. So remote patient monitoring falls under a family of CPT codes in the Evaluation and Management, or E&M, family of procedural codes. The codes that that cover remote patient monitoring are 99453 to 99458. At a very high level overview, the 99453 can be billed once upon a patient's enrollment into the program. This covers educating the patient on remote patient monitoring, providing them the device, any troubleshooting, onboarding, informing them on what they might expect from a copayment or co-insurance standpoint, really making sure that patients are very educated on the program. And this code is reimbursed for around $19 at the 2024 average payment rate and is billed once upon a patient's enrollment. I want to take a second to highlight the 99453 and the recent Peterson article and other publications that have come out that have found after surveying patients participating in this program and their own analysis that patients aren't being properly educated, that the rate of the 99453 being billed and its correlation to patients feeling properly educated and onboarded to a program leaves a pretty significant disparity. And something that Impilo does really well is leveraging our support services and our Engagement Plus support model to actually provide a high level of personalization to this patient education and onboarding, as well as documenting it for the purposes of billing the 5.3. Just to call out as a way that Impilo can help support really educating the patients and making sure that they enter onto the program in a strong manner. Moving on to the 99454, that covers the device and the monitoring and the transmissions. That is achieved if a patient transmits 16 readings in a 30-day period, meaning that at minimum, patients have to take whatever vital is being tracked 16 times. And if they do, this code is billable. And that can be a claim for the 99454 can be submitted every 30 days, assuming that 16 readings are achieved. And the 2024 average payment rate for that is approximately $46. The 99457 is the clinical review and monitoring component to the remote patient monitoring family of codes. This is achieved if 20 minutes of time of clinical review is spent reviewing patients' transmissions, their readings, any established care plan goals, any progress to achieving those, medication management, things of that nature. All of that activity has to total 20 minutes. And within that 20 minutes, interactive communication has to be established with the patient. And based off of a CMS ruling, interactive communication is defined essentially as a phone call, meaning that patient has to be spoken to once during the calendar month within that 20 minutes of review in order for the 99457 to be billable. And this is where effective documentation and effective functionality with whatever platform or software you are using to track incoming readings is crucial, because documenting that 20 minutes were spent through time tracking as well as interactive communication being established is one surefire way to reduce the amount of times that the 5-7 is denied. And then moving on to the 99458, that is an add-on code to the 5-7. It needs to be billed in addition to the 5-7, and essentially means that an extra 20 units of time was spent reviewing that patient's transmissions, that care plan, clinical activity within the calendar month, within that billing period. So the 99458 can be billed multiple times if increments of 20 minutes are spent. For example, if a total of 60 minutes were spent, 60 minutes of clinical activity were spent on one patient in a calendar month, then the 5-7, in addition to 2 units of the 5-8, can be billed for that one patient. So at a very high level, that's an overview of what the CPT codes are for remote patient monitoring. And as a transition to discussing the upcoming updates to the 2025 physician fee schedule, one of the first updates is a reduction in the average payment rate. The 2025 fee schedule it will display or take into factor a reduction of 2.93% in the average payment rate compared to 2024. So when trying to estimate what the payment rates will be for 2025, 2.93% less than what the 2024 payment rates are a good way to get a baseline if you're trying to estimate potential revenue from a RPM program. That takes us to the updates for 2025. But before that, I want to turn it back over to Chelsea if her or Josh have anything to add.
Yeah, I have a few things to just add into this. So, for those of you who are joining us who are running RPM programs today, you're probably very familiar with these codes. And it's probably, you've seen a lot of kind of interest in these codes kind of boom during the pandemic and then kind of stabilize in the last call it year or so. And what we've seen is a lot of innovative use cases being used in RPM across different clinical segments. And obviously, a lot of what we see today is in the cardiology space and primary care. But more and more, we're seeing different use cases in pulmonology, in pediatrics, and in post-discharge type of programs, not always in, billable formats like this, but we're seeing an ever-growing use of remote patient monitoring, and especially, a use of this as these codes have come out. And so I'll pass this back to Harsh to kind of talk about what's happening in 2025. But as many of you know, there's some bigger changes happening kind of going into 2026, and we'll highlight that too. So,
All right. Thank you, Josh. So yes, albeit 2026 does potentially bring some more exciting updates to the remote patient monitoring and virtual care space. There are some updates for 2025. The first notable update in relation to remote patient monitoring is a unbundling of the codes utilized by FQHCs and RHCs. So starting in 2025, RHCs and FQHCs will report individual CPT and HCPS codes that describe care coordination services instead of the single HCPS code G0511. So a notable change to the 2024 fee schedule was the ability for FQHCs and RHCs to bill for remote patient monitoring services under the care management family of codes G0511, previously used for chronic care management, principal care management, behavioral health integration. So 2024 was the first year that these very crucial facilities, often critical access health centers and facilities that provide very important care to historically underserved communities were able to be reimbursed for utilizing remote patient monitoring for the monitoring of physiological parameters outside of the confines of an office space. So 2024 was a very big development for FQHCs, but they were restricted to billing RPM through the G0511 code. So what that means is if 16 readings were achieved and that 99454 CPT code, the requirements for that were met, 1 unit of G0511 could be billed. If 20 minutes of time were spent on a patient reviewing, even if 40 minutes or 60 minutes were spent reviewing, facilities were only able to bill the G0511 once. And while the reimbursement for this code was a little bit higher than the typical CPT reimbursement rates for the 5.3 to the 5.8, they were essentially restricted in the amount of time they could spend. They were not reimbursed at additional increments for more time spent. So this change will do a few things. One, it will actually reasonably reimburse a provider for the time spent needed to manage more complex cases, and it will increase the potential ceiling of what these facilities can collect on a patient, on a complex patient, given that there are more codes that they can utilize for more time being spent. That being said, it is I think in my opinion, a great development for FQHCs and RHCs that will allow them to, better provide care on some of these more complex cases. Then going into the second most notable change to RPM is the creation of Advanced Primary Care Management APCM family of codes. So the APCM is Medicare's newest initiative to help primary care providers deliver continuous proactive care to patients with chronic conditions. Essentially would be a flat fee per primary care patient per month, with the very interesting addition of no need to track time. So it removes the time-based component of chronic care management, principal care management, transitional care management, and reduces the administrative billing burden and increases potential profit opportunities for primary care organizations in utilizing these codes in addition to remote patient monitoring. While these codes cannot be concurrently billed with chronic care management or transitional care management or principal care management, they can be billed in conjunction with the remote patient monitoring family of codes. So the combination of utilizing both the APCM codes and RPM codes provide the opportunity to provide a higher standard of care through these new digital health technologies, as well as being reimbursed for a more preventative, holistic approach to chronic disease management at the primary care level. So two interesting changes, not nearly as exciting as the proposed change for 2026 with the reduction of the amount of transmissions needed to achieve what is now the 99454 and presumably will be an additional code for a lower threshold of transmissions. Still notable changes, and I think supports the increasing trend to recognizing the value of these digital health technologies and connected care models of care delivery. That takes us to the next slide, which is circling back to some of the specifics and best practices for billing and RPM. But before that, I will turn it back over to Chelsea or Josh if they have anything to add.
Yeah, I'll just add a few things here. What a lot of these changes speak to, and obviously what's happening in 2026 is obviously insurers being more willing, more interested in incentivizing kind of this proactive care, ongoing care at home and remotely. And especially as we go into 2026, we're seeing a lot of our customers and potential customers look to set up base capabilities around remote patient monitoring, because they just see this as kind of being the status quo in the future, and how they deliver primary care or more virtual and more ongoing care, as a kind of a regular thing that people expect. So yeah, so excited to see what more of our customers do in 2025. And yeah, so pass that back to Harsh for the next slide.
All right, thank you, Josh. So circling back to what information do you need to bill for RPM? And essentially, it boils down to the same information that you would need to submit claims for any medical procedure. But the nuance being that whatever vendor or organization that you go with to help support your RPM programs should have the capabilities to visualize this information and export this information in a way that is easily visible, easily usable, and seamlessly integrates into existing revenue cycle workflows of whatever organization is deploying the program. So at its very core, the information that you would need to successfully bill a claim for RPM is patient information, your full name, your date of birth, your insurance demographics, your provider information, the rendering provider's name, remembering that the 5.7 and 5.8 codes can be furnished under general supervision of the rendering provider. What that means is that a member of the clinical staff, an MA, an LPN, a CNA, whoever that individual may be, is able to do the clinical monitoring, reach out to the patient, do all of the documentation under the supervision of the provider whose NPI the claim is being billed under. So something that is important to, visualize very easily on whatever software or vendor you're using for your RPM is who that rendering provider is, what the NPI is, what the place of service is, going into service information, the dates of service, diagnosis codes, procedural codes, any additional information on what the patient achieved during that time frame. For example, patient achieved 16 readings between date X and date Y. Additional information such as billing notes, place of service, type of service provided, as well as the ability to provide supporting documentation, meaning a log of readings with dates and timestamps, a log of the clinical monitoring activity through time tracking, or a ability to export any notes that were taken along the lines of furthering a patient's goals, health goals, or reaching certain medication milestones. All of this information are things that you need, components that you need to successfully submit a claim for RPM services. And utilizing a organization like Impilo and our platform helps you visualize that information very easily, whether it's for an organization that is directly submitting these claims or for a organization that is assisting or providing services to an individual organization directly providing healthcare delivery. Regardless, all of these are very crucial components to be able to visualize on a platform. And that takes us into utilizing this information for best practices in RPM. And what that boils down to is a couple of process-based just suggestions, best practices. From our experience, what we've noticed is enrolling all of your new patients on the same day, either on the first of each month or a prescribed date, just to keep the billing periods of your patient population very clean. All of the patients are enrolled on the same day. They end the billing cycle on the same day. It makes reporting and tracking and claim submission that much easier. And that takes us to sort of the next best practices, which is submitting all of your RPM claims on the first of each month. With any program like this, it gets a little confusing, given that patients theoretically could complete their 16-day readings and achieve billability at different days throughout the billing period. They could not answer the phone on the day that your clinical staff has scheduled making those calls and give a call back at a later date. So keep waiting until the end of the month or a prescribed claim submission date keeps sort of organization and tracking of patient activity a little bit more clean, a little bit more efficient, and utilizing a software that can visualize and track this, such as our Impilo software, is a very effective way to make sure that you keep your dates straight, you keep your readings straight, and reduce the possibility of any denials along those lines. Just another additional call outs from our experience. The date of service for the 99453 is generally billed 30 days after the patient has taken their first reading, meaning that the first time that you are submitting the 99454 and potentially the 57 is when you would submit the 99453 with any relevant documentation surrounding patient education and patient consent. And then along the lines of dates of service, the dates of service for the 54, 57, 58 should be the last day of the billing cycle. As I mentioned previously, enrolling on the same day, ending on the same day, and submitting your claims all at once are generally what has worked the best for any organization that is directly submitting claims for RPM to various payers. I think that's about sums up this slide. I will
Yeah.
take it back to Chelsea and Josh.
Yeah, definitely. Harsh. Do you actually mind answering a question right now? Who are the typical patients who are reimbursable for RPM?
Right. So with RPM being created as a Medicare program primarily, as of now, the program is offered as a Medicare Part B service to all Medicare beneficiaries, and by extension, the majority of Medicare Advantage plans as well. I will caveat this with every payer is different, and for specific coverage for RPM services, always consult a representative at that specific payer for more information about coverage. But as a general rule, Medicare patients are the ideal candidate for this program. And taking that one step further is Medicare as a primary and having a secondary or Medigap insurance, whether that is commercial or a state's version of Medicaid, is what I would say the most ideal patient population for RPM, given that there is a 20% insurance amount associated with all Medicare Part B services, and that secondary or supplemental insurance would cover the copayment or coinsurance amount, meaning that a patient with dual coverage would pay nothing out of pocket for remote patient monitoring services, whereas straight Medicare or potentially a Medicare Advantage plan might have that 20% or some amount of patient responsibility for participating in the program. So long-winded way of saying anyone with a chronic condition or acute condition is technically eligible. Medicare is ideal. Medicare with a secondary or dual coverage is extremely ideal. And as you move on to private payers or commercial insurances, the authorization for participating in remote patient monitoring will default to the typical pathway of getting a prior authorization or any of the admin work associated with getting those services covered. If that answers your question, Chelsea.
Yes, thank you so much. It does. Josh, do you have anything to add before we move on?
No, I actually I lie. Uh, you know, one thing that, we see a lot of our customers do when it comes to billing for RPM and kind of how it's paid for, um, you know, every model is slightly different, and we're, as Harsh even alluded to with his answer before, every insurer is going to have a different policy around what they cover, what they don't cover. Um, but we're seeing more and more interest in this, being a benefit, whether it's, something that's covered under a certain CPT code, or it's something that's being offered by an employer, or it's being offered as a kind of supplemental benefit or something like that. Um, and so the way it's paid for is something that we'll see a lot of changes towards in 2025. And obviously, with the new administration, there's a lot of things up in there of what changes, what doesn't change, and how it all works. But the big thing that we do see is just it is becoming more status quo to include some sort of monitoring in your kind of virtual care programs. So, hand that back to Chelsea. Take us to the next slide.
Awesome. All right.
All right, I will jump back in. So how we at Impilo can help. As I had mentioned in the initial slide on the codes, provide patient enrollment and education. So part of what Impilo can offer as that, infrastructure operational layer to delivering RPM is the direct shipment of devices to patients. onboarding and patient education services, and the ability to document that onboarding via our clinical notes feature to submit claims for the 99453. And as I mentioned before, there has been a lot of discourse just in the space, in the industry, about the 99453 and properly educating patients on not only the value of the program, but what their responsibilities are from a data transmission standpoint and answering the phone to actually engage in their care standpoint, but also, really what informed consent is and knowing what the potential co-payments or patient responsibility amounts are and what their participation in the program would look like in all aspects, clinically, financially, from a time perspective. So something that we can do very well, and we've seen a lot of success with helping our customers grow, is being an additional layer of providing that onboarding, no matter how patients are enrolled, whether it's in clinic or direct to patient shipping, utilizing our team and our focused resources to properly onboard and educate patients is something that we have seen a lot of success with, not only from the acceptance of claims submitted for the 99453, but from patient satisfaction and provider satisfaction. So definitely something when thinking about structuring a remote patient monitoring program and the billing implications, a strong onboarding as we offer really helps a lot with patient satisfaction, but also patient attrition. A common issue with RPM programs is a bolus of patients being enrolled and very quickly dropping out of the program after day 45 when they get that first EOB or they get that first monthly phone call. So not only does it provide, a better experience for the patient, it actually does have significant financial implications, being as you have the ability to retain patients on the program for longer periods of time than if you did not have a strong strategy for that patient education or the 99453. Additionally, how Impilo can help is through our EHR integration capabilities. And this is definitely something that is of interest to anyone in this space. And I highly suggest that anyone interested reach out to our team for more information on what our capabilities are for integrating with various EHRs. For example, we are a preferred partner in the Athena One Marketplace. We do have very deep integrations with Athena and the ability to aid in your claim submission workflow, whether that is automatic charge captures, pushing supporting documentation into patient's chart, pushing discrete data into where it needs to go, document routing, whatever that may look like for your particular use case. We are happy to take that conversation a step further. And that's definitely something I would implore you to reach out to Josh and our sales team. We have a lot of deep expertise in EHRs on the team and are happy to share what we know and hopefully come to a solution that is beneficial for everyone. And on that note of, EHR integrations, our clinical documentation support is something that is not very commonly addressed as a important capability for any RPM vendor or organization supporting RPM, but the ability to generate exports, not only of readings, but also of the clinical activity through our clinical notes feature is something that is not only useful from a compliance purpose of having, those exports in a patient's chart, it's in your EHR for any potential audits or compliance actions down the road, God forbid, but also for claim submissions. If, your particular clearinghouse or use case has the ability to support to upload supporting documentation to the claim upon submission, instead of sending it over when you get a denial for, medical records or medical necessities, that is something that we have seen a lot of organizations that we work with find value in, is the ability to generate these individualized reports for patients and use that not only for billing purposes, but more so for just record keeping. So 3 ways of many that Impilo can help empower not only organizations standing up their own RPM program, but organizations that have a virtual care offering or a digital health solution. As Josh mentioned, device-based care is, only at the beginning of what it can become, and the horizon is virtually endless in terms of its value and its use case and its implementation and deployment. So Impilo is poised to help in many different ways and also able to move quickly and work with your organizations to help better achieve our intended outcomes. That being said, I think that about wraps up my portion of the webinar, and I will kick it back to Chelsea and Josh.
Awesome. Josh, do you have anything to add?
No, well, I always say no, but yes, a little bit before we go into our Q&A. I think, one thing that, not so much highlighted here, is this, we're talking more about our services and how we kind of really support RPM, but in terms of the format, in terms of how we can support you, a lot of our customers utilize our technology and services through different, call it interfaces. So we have our API, which we did a great webinar on a couple weeks ago. A lot of people interface us through there. Harsh talked about the EHR side a bit. We interface through EHR, and then we obviously have our platform and application, which people use too. And really, our big thing is we want to help people who are growing these types of programs, and that's where we provide the most value. When you're scaling and kind of growing a remote care operation, and especially as you work across more EHRs, more devices, more geographies, that's where we as a solution make the most sense. So I really appreciate, everyone joining. And if you have questions, and I don't know if we've been collecting some already throughout the presentation, please submit them, and we can wait maybe a minute or so here and see as they come in, and then can do our Q&A before we end for today.
Yeah, thanks, Josh. Yeah, some actually came in. So let me go to the next slide. So if any popped up after everything that Josh and Harsha talked about today, feel free to still enter them into the chat and I will get to them in the last couple of minutes that we have here. But one question is, does Impilo help with enrollment? Josh, you mind taking that one?
Yeah, yeah. So I would think of Impilo just generally as how can you use us as your operational infrastructure? We don't touch the clinical, but we'll help handle everything from enrolling your patients if you'd like us to. It's all done in a white labeled way. So we're calling on behalf of Dr. Smith, Dr. Josh, Dr. whomever, and it can help with that. Um, the other thing that we do, kind of going off of that, is we can help capture consent for the process, as well as do welcome calls and set you up for a program. So if that's something you're interested in, definitely reach out and we can go into how that all works.
Awesome. Thanks, Josh. Another one that was asked was, what do you see as the most common conditions people are monitoring in RPM? Harsh, do you mind taking that one?
Yeah, of course. So off the top of my head, I'd say hypertension is probably the most commonly monitored disease state for the purposes of RPM. But something of note, and just something that I've noticed, is that there is a growing adoption to utilizing RPM for congestive heart failure management. So heart failure management, short of implantable device, is very much you know weight fluid monitoring and more of health coaching to get a patient towards the four pillars of GDMT. So in terms of a use case for RPM, I am seeing, just as the incidence of heart rates increases, estimated 8.5 million Americans by 2030 are going to be suffering from CHF. I'm seeing a growing adoption of organizations structuring heart failure management programs built on the RPM codes for reimbursement.
Excellent. Thanks so much, Harsh. And it looks like another one says, which Josh, do you mind taking this one? It kind of goes with the first question is, what is the typical onboarding timeline?
Yeah. So that's really dependent on how you're utilizing us. And I assume this is in reference to onboarding with us. So I'll take it from there. But if it didn't mean that, feel free to reach out to us. If you're using our API, we've seen people do that in a week. We've seen people do that in 6 weeks. all that good stuff. If people are not using our API, it's really as soon as you select what you want to put in your catalog for devices. Um, and once we have that, we can start shipping and you can start running your program right away. So it's again slightly different depending on how you interface with us, and if you have your kind of ideal state, if you will, pick before you start signing up with us. So
Awesome. Thank you. And we're going to do one more with the timing being perfect. So do you have resources to help with these or to help with implementation under these new guidelines? Josh, do you mind taking that one again?
yeah, sure. So as you can tell from Harsh and what he spoke about today, we have quite a lot of people on our team, especially Harsh, who know a lot about how all of this works, the do's and do nots, and then we also have other team members and resources that we can provide to help set that up. From an implementation standpoint, when you sign up with us, you get assigned a lovely account manager as well as an implementation manager. We create a curated plan that allows you to kind of go from 0 to 1 from starting your program or starting to scale it with us. And that would include everything to do with the billing and what you need to know there. Um, so, yeah.
Excellent. And if we did not get to your question, definitely feel free to reach out to us, sales@impilo.health. But that concludes our webinar today on CPT billing for RPM and what to know for 2025. If you have any questions that pop up after today's webinar, maybe a week from now, or are interested in learning more about our offerings, please feel free to reach out to our team at sales@impilo.health. Once the webinar ends, there is going to be a brief survey, and we appreciate your participation in that. And make sure to keep an eye out for new webinars in 2025. We have some exciting ones being planned, and I just want to thank everyone again for joining us, and we will see you again soon. And thanks again to Josh and Harsh for joining us for today's conversation as well.
Thank you very much, everyone. Hope you have a good rest of your day.
Yeah, everyone.